So welcome, everyone. I'm delighted to be joining you as chair of this London Global Cancer Week session. I'm Clara McKay. I am CEO of the World Ovarian Cancer Coalition, and we are a global not-for-profit that works with 200 patient advocacy organizations worldwide. Our coalition's vision is a world where everyone at risk of or living with ovarian cancer has the best chance of survival and best quality of life possible wherever they may live in the world. So the focus of this session, the Venus Cancer Project, is very near and dear to my heart. This important project aims to examine why quite significant differences in survival up to 5 years exist between high and low income countries for breast, cervix, and ovarian cancer patients. So I'm joined here today by two of the researchers that are leading on this project. And for the next 45 minutes or so, they're going to take you through an overview of the study and then share some of the insights and patterns that the data is showing to date. And for this session, we're looking at the ovarian and cervical cancer data. So first, I'm going to hand over to Professor Claudia Alemany, who is Professor of Global Public Health at the London School of Hygiene and Tropical Medicine. A long and distinguished career in international comparisons of trends in cancer survival, high-resolution studies, and work on avoidable premature deaths, all with a focus on impacting on cancer policy. Claudia is also co-principal investigator for the CONCORD program, and in 2017, she obtained a European Research Council Consolidator grant to carry out this worldwide study, the Venus Cancer Project. She's joined by her colleague, Veronica DiCarlo, who also works for the London School of Hygiene and Tropical Medicine, also involved in the CONCORD program and working on the Venus project as well. So Claudia, I'm going to hand over to you to provide an overview of this study.
Thank you very much, Clara, for your nice introduction. Thank you very much. Good morning, good afternoon, or good evening to everyone, depending on where you are. I will just summarize for you the key aims of the Venus Cancer Project. And then I will focus the first presentation on ovarian cancer. Then Veronica will follow up with cervical cancer. Please note that usually we presented the results for breast cancer so far. So this is the very first time that we present these results for ovarian and cervical cancer. We didn't have the chance to discuss with cancer registry involved. So whoever is in the audience and wants to join the discussion is more than welcome. So I just remind that the Venus Cancer Project started after publication of the CONCORD 3 results. These graphics show the 5-year net survival for the most recent period available, 2010-2014, for breast, cervix, and ovarian cancer. For those of you who are used to this graphic, the estimates are organized by continent: Africa, America Central and South, America North, Asia, Europe, and Oceania. And within each continent, the estimates are ranked from the highest to the lowest. You should also look at the flags close to the estimate, because we indicate when an estimate is considered less reliable. However, the general message from this graphic is that 5-year survival for these 3 cancers varied widely worldwide. We know for breast cancer with good prognosis, cervical relatively good, at least in high-income countries, but also for ovarian cancer that is considered a silent killer. So the question was, why are these differences so wide in the world? Is this due to different biology? Is the disease different? Is the pattern of care being different worldwide? Or there are other aspects of the society, such as education, socio-economic status, that may explain these differences? So this Venus Cancer Project had 2 aims. The first was to set up the so-called high-resolution studies to describe the pattern of care both in high-income and low-middle-income countries, and to monitor adherence to treatment guidelines. The second aim that I will just touch on, but it will not be covered during this presentation, is to look at the 20-year trends in avoidable premature deaths, where for avoidable premature deaths, we mean the deaths that could be avoided in a given country if survival in this country was as high as survival in another country with the highest figure. And for this, we monitor trends from 1995 to 2014. In the high-resolution studies, we had to start a new data collection, asking registries to collect 1 year of complete incidence that originally, by the protocol, was meant to be 2010-2014. But since this project was heavily impacted by the pandemic, if there was a good thing out of it, is that now we have more recent data. So we have 1 year of incidence during 2015-2018, and most registries submitted data for 2018. These high-resolution studies are meant to collect detailed information from medical records on staging procedure, biomarker, and treatment. And as mentioned, just for the avoidable premature death, we had already the data in the CONCORD database. But today, we will focus on the high-resolution studies. So it took a long time to build up the protocol, to develop the protocol. We worked on the protocol since 2018, when the project started. We had the first working group meeting in Arequipa. This was followed by 3 specific set of questionnaires to ask registries which variables were available in their area and what would be the completeness. So after a long debate and several other meetings during 2019 in various areas of the world alongside major conference, we finalized the protocol. In this list of meetings, there are also those in which we presented preliminary results immediately after the pandemic. But the protocol was finalized in November 2019. We called for data in December 2019 with the first deadline for data collection being June 2020. So you can imagine what happened to this. We postponed and postponed and postponed the deadline because the pandemic impacted the world in different times, impacted also us. We couldn't access our secure annex where we are allowed to do the analysis. So the data quality control have been ongoing for a long time. Now they are actually finished, but some registries still would like to submit their data. So while we are finalizing the analysis, we may have still to do some. One nice aspect of this project is that the ERC Consolidator grant allowed me to support 11 registries in low and middle income countries to collect this data. But you cannot imagine what a nightmare was to do these subcontracts, legal binding contracts between institutions to transfer money during the pandemic. And in some contexts, we offered this support to up to 20 registries. And in some contexts, after going through all the contract, having it signed, then the money couldn't be transferred, either because they couldn't receive the money from the UK or because they couldn't open a bank account. Another nice aspect is that we were able to support 17 colleagues from LMIC to attend international conferences, as well as the working group that we arranged alongside the conferences. And this helped creating a good engagement with all colleagues worldwide. These are the 11 registries that received financial support. Not in every context, financial support helped to collect good and complete data, but in particular, this happened in Thailand, inclusion Quito, where the financial support demonstrated that if registries are adequately supported, then this data of high resolution can be collected. So this is the current database that you see here. You see that we receive data from 89 registries worldwide. And here we are talking about population-based data. So data on cases data on all cancer patients collected in the area covered by the cancer registries in 37 countries worldwide. In total, for breast, cervix, and ovarian cancer, we have over 300,000 records in the database. So this is the first and largest population-based database in the world, collecting detailed information on staging procedure, biomarkers, and treatment for these 3 common cancers in women. And it will allow description of the disease biology, pattern of care, and at least short-term survival. We were hoping to update the follow-up to 5 years, but is uncertain whether we could do this by the end of the project. And all of this will provide actionable evidence for policy making on all inequalities in the world. And it will also, in particular, since this is a European Research Council consolidator grant, it will help also to update evidence for the EU guidelines on cancer control. So if we move on, now the focus is going to be on the ovarian cancer, for which we had over about 21,000 cases worldwide. And the first thing that we tried to do is to look at the stage distribution. First of all, to get this information is very complex. We allowed registries to submit data with the tumor nodes and metastasis classification. That should be the gold standard, but several registries submitted also the FIGO stage or the SEER summary stage. So a big work was to harmonize all these stage information and group them in early, this T1 and 0 and 0, local regional, that it could be T2-3 and 0 and 0, or T1-3 and plus and 0, then metastatic, and then we still have the unknown even after combining all this information. So if you look at these results that are again organized by continent and within each continent by country, you see that this, leaving aside some exception where the proportion of unknown is very small, less than 6%, in most countries this proportion is still around 30%. And something that I didn't mention is that even before trying to harmonize this information, we selected registries with at least 70% of information available. So in high-income countries, while in low and middle-income countries, we accepted whatever information was available because we thought it's relevant at least to try to describe the situation. So if we look at this graphic, we see that the early stage varied between 14% to 50% in high-income countries, but it generally within 20 and 30% and less than 30%. And advanced stage is particularly high, the proportion of advanced stage particularly high in Central and South America, and in New Zealand as well. So we also looked at the morphology distribution. We know that in ovarian cancer, we have 2 main types, type 2, that is more frequent and with poor prognosis, and type 1, less frequent with better prognosis. What is immediately evident that in most countries, this proportion of type 2 epithelial tumor is above 70%, while the proportion of type 1 is generally lower than 20%. So if we look at the early stage tumor, this is the distribution by continent. So Africa, America Central and South, America North, Asia, and Europe. We see that this proportion varies from less than 20% to 50%, is so particularly high in Norway. And if we look how these early stage tumor were treated, sorry, is not moving. Okay, we see that early stage tumor, very localized, are all treated with surgery. Now, if we look at the same early stage and treated with chemotherapy, we see that this the proportion of these women treated with chemotherapy is lower and is only relatively higher in Ecuador. Moving to the advanced stage, we can see a much wider variability in advanced stage in the world, from less than 20% in several European countries to over 80% in Cuba. And these metastatic cancer are roughly, let's say, less than 50% of these metastatic cancer are treated with surgery. While if we look at chemotherapy, most of them are treated with chemotherapy. Let's say more than half of them are treated with chemotherapy in Europe or in several high-income countries, but this treatment is higher in Central and South America. So as point for discussion, we could see that the type 2 tumor with poor prognosis are the most common type worldwide, while the type 1 that are generally around 40% in Singapore, Thailand, and in South Africa. The early stage is unfortunately still less than 30% of the women in most all countries, and most of them are surgically treated. The advanced stage has a very wide variability, especially in low and middle-income countries. And we are still trying to do more in-depth analysis on treatment, where we would like to look at the probability of this patient to be treated according to clinical guidelines, or look adjusting by stage, tumor subtype, and age. But this is still to be finalized. So if we can have any hints from the audience, that would be great. Thank you very much.
Thank you, Claudia. Wow, that's really, really, really interesting. I'm sure there'll be a lot of questions kind of off the back of that, including from me. But I think what we'll do is we'll carry on. And Veronica, you're going to share with us the cervical cancer results, and then we'll have the time at the end. So I'll hand it over to you. Thank you, Claudia.
Okay. Can you see my screen? Yeah? Okay. So the second part of this presentation will focus on patterns of care for cervical cancer. The same slide that Claudia showed you before, I just want to focus on the total number of cases that we've received for cervical cancer. We are analyzing data for over 60,000 cases, most of them located in Europe, and less than 1,000 cases in Africa, and particularly in sub-Saharan Africa. This slide shows the cervical cancer's distribution by stage at diagnosis. As you can see, we categorize stage at diagnosis in localized T1 and 0M0, regional T2, 3, and 0M0, and the node positive tumors, and then the T4 and locally advanced and metastatic. We also have a category for unknown stage in red. Countries are ranked by continent, and within each continent, from the highest to lowest proportion of localized disease. Just to note that the star next to each country indicates whether we have national coverage of the population, while the number in brackets represent the number of registries that submitted data for this analysis. So as we can see, the proportion of localized disease was approximately about 30 to 35% in Europe, and between 42 and 61 in North America. The availability of stage information, unfortunately, was quite low for some low and middle income countries like Colombia and to some extent also Brazil, while the availability of stage was much better in high income countries and, with some exception, low and middle income countries in Europe. To note, while the proportion of localized disease was around 30 to 40% in high-income countries, in sub-Saharan Africa, namely Nigeria, South Africa, and Uganda, none of the women were reported with localized disease, so T1 and 0M0, and this was particularly striking. However, if we just look at this distribution, we will have only a partial idea of what is the capacity of a country and the health system to detect cervical cancer, because we know that a very big proportion of cervical cancer is diagnosed as in situ. So in these two columns, you can see the number of cases submitted and the total proportion of in situ cervical cancer. So first of all, we must say that not all the registries and all the countries record information on in situ tumors. For example, this information was only recorded by one registry in the United States because in situ cervical cancer is not a notifiable disease. However, for the countries for which information on in situ tumor is available, we can see that the proportion was quite high in Europe and up to 90% in Slovenia, in Belgium, and in Switzerland, but also in the United States and Canada. So almost all of the cervical cancer were detected as in situ. So the full picture of the stage distribution can be only commented when we also have the distribution of and the number of in situ. We focus then on the adherence to clinical guidelines, and here in this slide you can see the proportion of women that received surgical treatment, again ranked by continent, and within each continent from the highest to lowest proportion of women surgically treated. As you can see, roughly the proportion of surgical treatment was quite high in Europe, but also in North America, and less so in Southeast Asia and in Latin America. If among the women surgically treated, we look at the stage distribution, we can see that over half of those women were early stage cervical cancer. This is true for Europe, for North America, but less so for Central and South America and Southeast Asia. And again, to stress the point that none of the women reported in women with cervical cancer reported in Africa were diagnosed with localized cervical cancer. And then we looked at and asked the cancer registries to submit information on the type of surgery, dividing between the simple hysterectomy, radical hysterectomy, and unknown. This graph shows a much lower number of registries and countries because, unfortunately, this information was not routinely collected by all registries. For example, in the United States, this information was not available. But we can say that roughly the proportion of women that received simple hysterectomy vary widely between 1% in Colombia to 60% in Belgium. Then we looked at the advanced disease. The proportional advanced disease was generally lower than 20%, with the only exception of Ecuador, Iran, and France and Estonia, where it was justly above, slightly above 20%. And then we looked at how many and what was the proportion of advanced women diagnosed with advanced stage that received radiotherapy or chemotherapy. And here, similarly to what we've seen for ovarian cancer, we could see that almost all women in Europe received, with advanced cervical cancer, received radiotherapy or chemotherapy. This proportion was lower in Southeast Asia. So we've seen as point of discussion, first of all, that the stage distribution the stage distribution needs to be carefully looked at only when we take into account in situ neoplasms. Unfortunately, in situ neoplasms are not registrable in many countries, as we've seen. We've seen also that early stage, so T1 and 0 cervical cancer, the proportion varies between 30 to 60% in high-income countries, but was less than 30% in low and middle-income countries, and no early-stage disease was reported in sub-Saharan Africa. This is particularly important because we know that incidence of cervical cancer is increasing in sub-Saharan Africa, and this can explain also why low survival was reported for all cervical cancer combined for sub-Saharan Africa. Simply the stage distribution is way more advanced in those countries than in the rest of the countries. Then we've seen that surgical treatment was available for 40 to 60% of women in most countries. And the radical hysterectomy was available in 40% or more women in several countries. Then when we focus on advanced disease, we could see that, first of all, advanced stage cervical cancer, the proportion was below 20% in most countries. And almost all of those women were treated with either chemotherapy or radiotherapy that were guideline compliant treatment. So the data from VENUSCANCER on cervical cancer are particularly important also in the light of WHO cervical cancer elimination initiative that has a target to reach by 2030, the so-called 90-70-90 target that wants to reach 90% of the young girls vaccinated against HPV, 70% of women lower than 35 years of age screened for cervical cancer, but also, and the last target is what is particularly important for us, 90% of women diagnosed with cervical cancer that receive treatment. So the information on the treatment on cervical cancer can help understanding whether the target of the WHO cervical cancer initiative can be reached hopefully by 2030. Thank you.
Wow, thank you both. That's so impressive, like just such an impressive study. And as you were talking about some of the challenges that you faced, it really rang true for me, certainly in the coalition, when we, simple things like wiring money, which you never really think about as a barrier, but in terms of the barriers for countries to coordinate together and participate in this kind of work, they're not insignificant. So, huge applause for you both in terms of the staying with the study and navigating your way around those many challenges. So we have some time for discussion, and I would encourage, please, attendees, please put your questions in the Q&A chat and we'll pick them up and discuss them. I have a couple of questions, and forgive me, I may have missed a few things on the way through, but a few things struck me, so I'll start off. And one would be, I was quite taken with in both the ovarian and cervical, the percent or proportion of unknown stage that was flagged up, and I don't know if you have any reflections on, is that an indicator that women are diagnosed so late that they don't do staging, they are just kind of they access palliative care, but there is no kind of active intervention, and hence the lack of staging data. Is that, do you have an understanding of what's behind the unknown stage, I guess, in both?
Well, we will look for sure more in depth, but generally, women with advanced stage are more in elderly women and with late stage presentation. Or
Yes.
with late stage presentation, for example, in LMIC, they may be younger, but still,
Yes.
with late stage presentation. And there are two components, that the stage may not be available at all, or it
Yes.
may not be available to the registry.
Right. Interesting.
Yeah. I was about to comment exactly that the availability of stage information depends also on the availability of the registries to receive this information. So in some countries, it's just complicated to go to the clinical record and collect all the information on stage at diagnosis. In some others, as you said, this may be an indication of advanced disease that perhaps are not staged simply because it's advanced disease, but for sure we will look at how the advanced or how the unknown stage are treated as an indication of whether they might be local stage or more advanced disease. But in some cases, it's only the registries. It's very difficult for the registries to collect this information.
Yeah, and also, even if in a way information on stage should be a given, a must have, the problem is that sometimes it's not even in the medical records.
Okay.
And not because the doctors do not know the stage, but just because they think, oh, I know the stage, maybe they just don't write it in the medical record.
Mm-hmm.
And even if it's not very believable, it's something that we hear a lot from cancer registries where they struggle to get this information. In an ideal world, this information should be transmitted from each hospital to the cancer registries. And as I heard recently in Beijing at the International Association of Cancer Registry Conference, this is what they are doing in Poland. So the information from all hospitals is submitted directly to the cancer registry.
Really interesting. And what I really like about the work that you're doing is that I think it actually is a study about cancer registries as much as it is about a study on kind of cancer, outcomes. So, and I think it really eloquently highlights, just the challenges that we have with access to data and I think generally support for the work of cancer registries. It's, in terms of cancer policy, perhaps overlooked. Yes,
Yeah, if I can Clara, I just want to also to highlight the fact that cancer registries very often deal with all cancers, all type of tumors. So perhaps their focus might be more on, because of a specific requests or because of higher incidence, might be more on cancers that have higher incidence, like breast cancer or, I don't know, colon cancer, while we are talking about two tumors that are very often neglected because their incidence is much lower than, than others. So, and the cancer registries are very often understaffed and under-resourced. So also collecting detailed information is very difficult for these reasons as well.
I think that's right. And I do think it's a really important highlighting the value of cancer registries and the really critical importance of support.
Yeah. And the lack of financial support that in many contexts they face.
Right. Exactly. Where there are many competing demands for resource, cancer registries are probably not at the top of the list because they're not something that the public particularly understand and understand the really significance of that in terms of cancer planning. We have some questions in the Q&A, so I'm going to...
Can I add one more thing? Despite what you have just said, the cancer registries are the core element of cancer control, because without cancer registries, we cannot produce any indicators that then policymakers need to plan the strategies for cancer control.
Agree. They're kind of the essential foundation for kind of good cancer control policy. So I have some questions here. So the first one says, and they all say thank you so much for the terrific presentation. So, you know, very, very well received. So the question is, I may have missed it, but to what degree are you able to look at guidelines concordance? And can you share those findings? And then a secondary question, have you published more since the last London Global Cancer Week? And the comment is many are eager to learn more about this essential work. So I think the first bit is about the what degree are you able to look at guideline concordance in this work?
Mm-hmm. Okay, maybe I reply for ovarian cancer, and Veronica, you go for cervix. Okay, so I think that many of our colleagues in the audience are used to our presentation on breast cancer, where there are clear-cut clinical guidelines, and it's easier, let's say in quote, to monitor the adherence to guidelines. For ovarian cancer, we tried hard to find the best way to do it, because we collected also detailed information. We tried to collect detailed information on type of surgery, but it's much more unknown than for breast cancer or cervical cancer. So it's a bit difficult to distinguish between the type of surgery, but even being more broad, we tried to look at the probability to being treated, to receive treatment, to receive surgery versus not receiving it. But I think we may have to dig a bit more by separating the subtype and even, maybe looking at the local regional cancer rather than only the early stage. Because we were not definitely convinced by the results. That's the reason why we decided not to include them in the presentation. But another point that I would like to stress, and if there are any suggestion in the audience, we used the same age group that we use for breast cancer, such as 15-39, 40-49, 50-59, 60-69, and 70 or older. And I was wondering whether, either for ovarian cancer specifically, if there is another age group that we should consider.
Right, that's interesting. Yeah. So it would be a slightly older population, probably compared to the breast and cervical. And
Yeah.
Veronica, we're going to.
And yeah, I was the same point is to do with cervical cancer. Because of the information of, as we say, in situ tumor is such high, over in some cases 90% of the cases are diagnosed as in situ cervical cancer. So this leaves as luckily a proportion of invasive malignancy, which is only and positively about 10%. So of course we want to look at whether the early stage cervical cancer are treated with surgery, and the advanced cervical cancer are treated with chemotherapy or radiotherapy. Of course, in this case, we may have issues in terms of numbers and power of our results, because they are based on a small number of cases, simply because luckily they are not diagnosed as invasive, but as pre-invasive lesions. So also around that, there is a lot of discussion on what can be the best approach to go on.
Yeah, really interesting. And I think the important thing is that it's a starting point, even if you look at the data and think I'm not, as you say, we need to interrogate it a bit more to feel confident in what it's telling us. It is the data is the starting point for that kind of exploration. So it's really important. I'm curious, and if you can speak to across the three, the breast, ovarian, and cervical, did the country level, did the trends from countries and continents, did they largely mirror each other in that, if there was lack of, low rates of surgery, does that, where you would expect to see higher rates or you want to see higher rates, did that trend mirror across your three kind of cohorts?
Well, there is obviously a big variability between high income and low and middle income countries. And that's the reason why we decided to do two separate modeling, because it would be unfair to compare, the situation in low and middle income with the high income.
Yes. But I suppose I'm thinking about if we say pick South Africa, is what you're seeing across breast, ovarian, and cervical
Yeah, what we could see, for example, but this was also the case for breast cancer, that treatment that required follow-up were less frequent in low and middle income countries because perhaps the resources are lower, and then it's, for example, and what we presented last year was for women with breast cancer and localized breast cancer, the proportion of women that receive mastectomy is quite high in low middle income countries because it's easier, quote unquote, to go for an invasive treatment rather than a less invasive that requires more follow-up. And the same we've seen for cervical and ovarian cancer to a different extent, of course. But yeah, this was the thing that I think was quite evident from the analysis.
Yeah, although, for example, for breast cancer, in the US, it was difficult to distinguish because we found a high proportion of mastectomy. And this is not because they are not following, the more strict guidelines that have been for, more over 20 years, but also because now the mastectomy is an option that women can choose, even when they have an early stage.
Yeah.
So everything has become a bit more complicated because the guidelines, rather than becoming more strict, they seem to be more interpretable, let's say.
Yeah, and taking into account the opinion of the patient that may decide, well, even if the treatment is what is suggested by the surgeon, I will rather prefer to go for a complete mastectomy, and especially among young women that are more informed.
Yeah, certainly. So in our Every Woman study, so that is a patient experience study that we've conducted across 22 low and middle income countries on ovarian cancer, working closely with patient advocates and clinicians and patients. But one of the things that is really clear in that piece of work is, the significance of distance between and travel time to your point of treatment, and that can, clearly have an impact on, I would say, choices that are made in terms of treatment options. So there are very pragmatic factors that also kind of impact on decisions about, best course of action. Can you tell me a little bit about how, because I think the really exciting piece of this is that just this enormous wealth of data now that you have that can inform policy decisions and how policy is shaped. So how will that go for, like, how can we ensure that this, that this data set actually is used in ways that, advance care and treatment for these cancers?
Well, first of all, we will try to select the most complete and accurate information to do the more sophisticated analysis, because that's the only way. And as I mentioned, we may have, to further stratify not only by stage, but for example, in ovarian cancer, also by tumor subtype as well. And again, it's a question of numbers, because even if this is a huge data set, when you start to refine your analysis, you may not have enough numbers to assess what you would like to assess. And obviously, we still need to talk to our colleagues in cancer registries, but also to clinicians to understand, whether the choice that we made are meaningful from a clinical, but also from a policymaking perspective.
Yeah, and if I can add, the difficulties of these studies precisely the amount of information. So as you say, to get to deliver a clear message, I think we also need to focus on specific messages and clear messages that we want to put out, or to the point that we want to make. And this is not always easy, because potentially we could look at many indicators, but what we are trying hard to do is to select a few messages that can be shared with policymakers that perhaps will not read an entire article of, I don't know, whatever tables or pages, but are interested, okay, what are the main findings of your study and how can we move forward? And this is the difficult part of the analysis as well.
Yeah,
Yes.
and another offset, sorry, that we didn't cover, and actually we are also looking at the time to treatment as
Right.
well.
Wow. That's really important. That's really interesting. I mean, it seems to me, and we talk about this a lot in terms of the work that we have done with the Every Woman study in low and middle income countries, and the great value of a global data set and global insight, like as what you've produced, is amazing and so useful. And then our ability as the community that works, the cancer community, to also empower local, national level and local action with data. So being able to sort of draw down or understand what this data is telling you about your own country context, and what that means specifically in relation to national kind of cancer control plans and priorities. So it's a beast, and it's complicated, but I think that we should all be really committed to supporting the dissemination of these really critical key messages, but also the use of the data at global and at country and regional level.
Yeah, and Clara, just to add that for registries, there are some cases where we have several regional registries within the same countries, and we know that there are also regional differences within countries. So it is also important to explore that, not only at a national level, but also at a regional level, to try to understand whether these disparities affect survival for women, I don't know, diagnosed, I'm doing the example of Italy, but in north of Italy and in south of Italy, because the access to treatment may be delayed in some regions compared to other regions, or the availability of treatment may be differential. So yeah, this will be another point that we aim at discussing with the registries, and yeah.
Really, I think a really valid and really interesting point. I suspect I mean, it wasn't in your presentation, but just as you're speaking, I'm wondering, and does the data set also identify ethnicity? Like, do you have the demographics? So it'll be very interesting as well. There's a
Okay,
whole analysis around that.
only for some countries, and we explored only the differences in the US, for example, and let's say that, for example, in the stage distribution, these were more marked for cervical cancer, but for ovarian cancer, we didn't see much difference. While normally, especially the difference between black and whites is very marked, that was not the situation, even in terms of the unknown information, that was very limited for both ethnicities.
Yeah.
Yeah. Go ahead, Veronica.
But we also aim at looking at for example, for the US, whether because we know that there are disparities in survival by race and ethnic groups. So whether the disease is diagnosed at a more advanced stage for ethnic minorities, or it is the access to treatment differential by ethnic minorities. Yes, so this is another point of our analysis.
Yeah, really important, really interesting. I have a question here, and it starts again with both presentations were awesome. So well done again. Although you have stressed that cancer registries are essential for cancer epidemiology, now health managers, also in LMICs, are starting to talk about AI replacing cancer registries producing data. and they're interested in your view about how that may turn out. So will AI kind of rock our world?
Sadly, this idea that AI can replace cancer registries starts to be diffused also in high-income countries, where registries are really under threat of closure because some politicians think that we can use AI, we can just give the data from any data set in the hospital and then that's it. You know, cancer registry is much more than that. You know, it's a group of people with a long-standing knowledge about the disease, about the data. They know inside out everything. And there is no way that an artificial intelligence on its own can do this. So the artificial intelligence may be useful as a support to cancer registries, you know, when they have a huge amount of data and they want to check consistency in some patterns, but there is no way that is going to substitute the human intelligence that is very much needed.
Yes, and you know, the collection and verification of data, you know, that goes into the registry, that is a human task, actually. Veronica?
No, I was over the last few years after the COVID pandemic, I think the conferences that we've participated, there were quite a few presentations about the support of artificial intelligence to cancer registries. And it was precisely as Claudia was saying, it's just a support, for example, to read clinical reports or, I don't know, massive amount of information that can be obtained on paper, for example, from a hospital. So rather than a person spending long time, so the artificial intelligence can be a valid support for that. But behind that, there is a person that actually is going to check whether these information that have been extracted are correct and actually whether they make sense. So in any way they can replace cancer registrars at all.
Yes, and you talked, I think, actually before we started this session, Claudia, you were at the international cancer registry meeting. Is there a good global kind of network, you know, a network of champions around cancer registries? Is that something that we can look to help strengthen the global system of cancer registries?
Yeah, there is the Global Initiative for Cancer Registries. That is an initiative that aims to establish cancer registration in countries where there is no registration, or to support cancer registries where there are. Where obviously they have been working for many years, but you know, this is a very difficult task. And that's the reason why in the recently announced CONCORD Lancet Global Commission on Cancer, we are going to stress the importance of cancer registration and how this should be not only expanded in the world, but make statutory in as many countries as possible.
Yes, it almost seems like it's an essential, you know, it's a little bit like it's the cornerstone of all the planning for cancer. So it's such an essential element to the program. So where do you go next with the study? Where are you in terms of your timelines? What do you, you're smiling, it's forever.
Well, as you know, the timelines, the pandemic really was a massive disruption, especially from this type of detailed data collection. So we ended up, you know, running analysis, cleaning them, writing up, and then having different data and different things, making our comment changing. So we really hope to have a series of articles very soon, you know, out in the public domain, where we can highlight, you know, the relevance of this data and how they can support policy making. And I really hope that our colleagues that are in the audience, those that are involved in the project, will be very keen to contribute to comment on these findings.
Yeah, and just to add that we received the last data set last week, basically, and we yeah. So, and there are still a few registries that are planning to submit in the next few weeks. So when everything seems like, okay, now we are solid, we have the final data set to draw our conclusion, then it comes, and we are glad because it means that really the interest around these studies is massive. But yeah, there is still a registry that's tell us, okay, now we are ready, can we send you the data? And that's great. So yeah.
It is. Yeah. And I was really struck as I was reading background papers, and COVID disrupted everything. And then, you talk about Brexit sort of threw things up in the air. And, there are all of these kind of things that happen that get in the way. But what I was thinking about was for those people, particularly in low and middle income countries on the ground, that are, often battling with pandemics and, civil unrest and the impact of climate change. And, it is their day-to-day kind of life that there are these, that these things are barriers and disruptors. But the level of commitment that it takes, I think, to commit to participating in a study like this is enormous. And I kind of really want to acknowledge that the level of commitment and the contribution that these individuals are making is, really significant given the circumstances of their local context. So it's hugely impressive that you've been able to do this, but also I think really heartwarming that there is so much interest and commitment to advancing our understanding in this way.
Thank you for highlighting this, because it's very important also to support our way of thinking.
Yes.
That you cannot exclude the data set from low and middle income countries because their quality is not as high as in high income, because there are people who make a lot of efforts to collect this data.
Yeah.
They do their best, and in any case, this is the only available information that we have, obviously to be taken with caution, with proper comment, but it needs to be really used as the starting points to build up on. And I sincerely hope that at least the registries that collected this data learn how to collect this data through our protocol, and they will continue after the study. Some of them, as I mentioned, 11 got financial support. I hope that this helped them to set up, all the connection to be able to collect this data. And I also hope that they will make clear that if they have that support, they can go on.
Yes, it is often the beginning for, I think you're absolutely right. And our experience is similar with the Every Woman study in that, some of the great, I think, add value of the work that we have done is that we can see now networks, clinicians networking with each other within countries in ways that perhaps they hadn't before, but really gaining a lot of benefit from those connections. So I think participating in this kind of study, as you say, even if it is and we must encourage rather than discourage participation, even where the infrastructure is poor and the data may be scant. But it's just so critical that we support this early start. And I do think that there's a great added value to the individuals involved and the registries involved that almost go beyond the data that's been collected.
Yeah.
We have about go ahead.
Can I add
No,
one
it was
thing?
yeah.
Sorry, Veronica, I just want to say this. I would like to thank the registries, especially in low and middle income countries, where they contributed data, even if they couldn't receive the financial support. But I would like to stress the point that a huge thank to anyone in high income countries, because in many high income countries, people are struggling to collect this data,
Yes.
and we are not allowed to support them financially.
Interesting. Very good point. Very good point. Veronica?
No, I just wanted to follow up on questions that we had on the Q&A. on the minimum of unknown information, the proportion by cancer site to be acceptable. So Claudia, I think, mentioned that earlier, that for low and middle income countries, we didn't restrict analysis on a given proportion on a unknown stage because we knew how difficult it was to collect it. For high income countries, we use a threshold of at least 70% of available information on stage. But generally speaking, registries either in high income countries either were able to submit a stage at a very and with a high proportion of known stage or not. So that made our life relatively easy.
Brilliant, brilliant. So we're at the top of the hour. I would like to, I'll give you a chance for some closing remarks, but I'd like to say from a World Ovarian Cancer Coalition perspective that firstly, this is a, really, really encouraging and welcomed contribution. But also as we're talking, I'm thinking about the power of bringing together the research community, the clinicians, the health policy makers, but also patient or advocates and patient advocacy organizations. I think the power of taking this forward will be drawn from our community and those really critical stakeholders together. So I look forward as a coalition to working with you kind of on this work, and just really keen to disseminate and promote and find ways that it can be useful in in practical and strategic ways. So just before we wrap up, is there Claudia and Veronica, any closing comments or remarks you'd like to share?
No, apart from thanking the registries,
Yes,
and
thank
the contributors. Yeah,
I agree.
Thank for me, and also thank you, Clara. We really look forward to collaborating with you.
Me too.
In the near future.
Thank you so
Thank
much.
you.
Thank
you,
you,
Clara.
and thank you for everyone who attended.
Thank you.
Thank you. Really
you.
interesting.
Ciao.